So what we're going to do is launch into the advanced care planning talk. I really think that this is just, we're in this incredible moment. As we all know, there are amazing challenges for the healthcare system in ways that we hadn't, that were really unimaginable. But we see that there are a lot of innovative things happening. And we also see that there's really this unprecedented policy response, federal, state, and local level. And certainly one of those opportunities right now is with advanced care planning. So I listened in, and I know Jeff Galbraith, who's also on the call, did as well, to a really interesting policy discussion talk from CTAC on Wednesday morning, all about advanced care planning and what we see nationally. So if anybody is interested in that, let me know. I can share the link with you. I thought it was really interesting what we're seeing nationally. And again, one of the things that they talked about was the opportunities right now for advanced care planning. So, and I really feel that this is a crucial, conversation, but also a crucial opportunity that we have. And, in the time of COVID, we know people can get sick very quickly. And sometimes, things happen in a matter of hours as opposed to a matter of days or years. And we also know that these conversations are especially important for people who are very seriously ill. Like, it's important to choose your agent, understand your wishes. If someone is appropriate for a POLST, very important to have a POLST and understand the conversations and the wishes that people have, especially if people are choosing to stay home instead of going to a hospital. And at the moment, the POLST is really the best way to have your wishes documented in terms of staying at home. But so again, we see that there's a lot of opportunities out there, and that these, these conversations are really crucial. So we have 5 local experts who are we asked them to talk a little bit about what they're seeing in their facilities, and then if you have questions, you can either type them in and we can read them out. I think that may be the easiest, or else later on you can raise your hand and then we can, we can answer those. So the first person up is Michelle Cantillo. Michelle is known to many people. She is the advanced care planning coordinator for Hawaii Pacific Health. Many of us have had trainings from her. And so she's going to talk about what's going on with Hawaii Pacific Health. Okay, Michelle, you seem to be unmuted, so go.
Hi guys, thanks for having me. Just a quick update. Just before COVID started, I actually finished doing ACP updates with all the clinic physicians, their staff, throughout the last year. So it happened to be perfect timing, because part of their qualities measures, as you guys know, is the 65 years and older. So I was really stressing to them, the usual feedback for us is not just doing the pulse, but making sure they're having good ACP discussions, doing advanced directives, etc. And so thankfully that was happening. And with the COVID happening, what we end up doing for us, more the geriatric and the palliative outpatient group did is more Dr. Winnie Sewin and Dr. Susan Price created, using this CAPC, Respecting Choices, a mixture of Vital Talks. They just used all their scripts and put it together to do an ACP COVID discussions. And so they started doing it with their patients via telehealth and telephone encounters. With that script being done, we also created a COVID-19 ACP discussion template in the EMR. And we also educated our complex care nurses who work with the patients getting discharged. So we encourage them to they already had the ACP classes, but they encourage them to bring up the COVID discussions as well, because these are very high complex, seriously ill patients. Not only did we reach out to those staff members, we also reached out to the inpatient social workers and the palliative care team. Because at that time, when COVID happened in April and and May, the census had dropped. It dropped everywhere for all of our hospitals. So they had opportunities, and then they didn't have any visitors. So they had opportunities to visit those those patients who needed advanced care planning. So the social workers specifically would they normally did that on a daily basis, but more specifically is to look and which would benefit from having those COVID discussions. And palliative care, it just depended. They weren't doing it 100%, but they would, as most of the COVID cases that did come in for HPH, the attending physicians, admitting physicians would keep that patient. They didn't necessarily want to pass it on to get more staff involved, only when it was necessary that palliative care did get involved. As of today, I did reach out back to those people that we educated. Geriatrics continue to do their COVID ACP discussions in outpatient. Palliative care on and off, and the complex patients, it just depends on the patients. We were thinking again to going back to the clinic doctors because the census was low, but because our numbers were good for a certain time, we didn't feel this high necessity to go back out to the clinics and do the education on the COVID specific related script. So that's one thing that we did. What we did do in a hospital is try to really push our doctors to get the surrogate information. The intensivists are pretty good about doing surrogate if there's no documentation on file. And through that process, we upgraded our surrogate paperwork, as well as create a smart phrase for the surrogate for the doctors to use. So we're pushing that on the hospice because we're good about doing it in the ICU, not so much on the floor. So that's one thing we did. As for me, in terms of, I was doing as necessarily, very rarely, and maybe I had more one-on-one patient and family ACP discussions, only as needed from the geriatric group when they needed more support because they didn't have other team members to help them. So I personally would do a one-to-one. We would go outside in an outside area at Straub or something like that. So or Capilani. Very rare. I have not had to use my public notary services, but I know I can use Hope for that. And in terms of the public classes, I was hoping of course, that was all on a hold. We have monthly ACP classes. My usual attendance ranges from 6 to 20 people. It just ranges. We had to put that on hold, and I was hoping to restart in July, but because the cases went up again, we put a hold on the public classes. So I'm experimenting with one group to do a Zoom, a family that wanted to come to July's meeting. So I'm going to try to work out a Zoom class just for that family. And then in terms of the staff education, we are restarting to do in July, the staff education. So the flyers are up to date on Kokua Mau. I know Marcus has uploaded the new flyers. We have 4-hour classes, we have 8-hour classes, and my first class is a 4-hour. And we are having restrictions of 9 attendees because we're gonna make it 10, including an instructor at the facilities, and they have to wear a mask, and we have to do the social distance, et cetera, and wipe down, et cetera. So that's gonna be starting in July for us. Another thing I'm doing on a side too, for this year, I'm looking at the data with all the patients that come in with pulse, and I'm looking to see, their COVID, did they change their wishes on the pulse, because that's something we hear are regarding, do they want full treatment versus the limited, did they change it back? And right now I'm not quite done with the data, but I'm not really seeing a lot of big changes like you would expect. Oh my gosh, I'm scared, I'm not gonna get the care I wanted. Right now it's the 1 or 2 patients that may have changed their pulse wishes, or 1 or 2 family, but it's not a lot right now. So that's the data I'm working on currently. So more to follow on that. That's it. Thank you.
Great. Thank you, Michelle. Always a lot of great things going on. I don't see any specific questions in the box, so maybe what we can do is carry on, and then we can ask questions afterwards. So the trainings, Michelle, just to clarify, are those open to the community like you've done in the past?
Yes, they're still open to the community.
Okay, sounds good. Okay, so thank you very much. Of course, I have all kinds of questions I could ask you, but we'll save them up to the end. And again, you can either type your questions for different people in, and we can ask at the end, so we don't interrupt the flow of the speakers. Okay, thank you, Michelle. So our next speaker is Amy Hamane. And Amy is a volunteer with Community First, which is a fabulous organization in Hilo that is doing, they have been doing all sorts of, for quite a while, advanced care planning sessions in Hilo, and and physicians can refer people to them, and they meet at the, whatever the proper title of that nice building is, that's the county's Elderly Affairs Division. So Amy, are you there? We need to put Amy onto to be the spotlight.
Yes, I'm here. Can you hear me?
Yes, we can. Great. So, and if you want to do a better job than I did, Amy, at explaining about what Community First has been doing as part of what's happening now, that would be great.
I think you did an excellent job.
Okay, good.
Prior to COVID-19, we were doing in-person workshops every month, except in December. And we've reached about 1,500 individuals thus far. In March, we held our last in-person workshop. We had 52 people pre-registered, but only 23 showed up, because by then folks were beginning to avoid group meetings. Of the 23, 18 completed their advanced healthcare directive. Now, over a year ago, we had been asked to do a Zoom presentation for a Kau senior group, but none of us on the committee were familiar enough with the Zoom process, so we just kept putting it off. But in April, we realized that COVID repercussions were going to be around for a while. So we attempted in earnest to adapt our in-person presentation for a Zoom presentation. 4 of us from our committee met quite a few times using the Zoom app, and by May we felt ready to give it a try. We invited those who had email and had pre-registered for our April and May workshops. Of the 13 people that we invited, only 4 expressed interest in the Zoom meeting. So we reached out then to those who were no-shows in March, but no one signed up from that group. So we ended up with only 4 participating in May. We didn't advertise outside these groups because this was our first attempt at a Zoom workshop, and we wanted to kind of control things just in case. The Office of Aging facility, where we normally hold our in-person workshop, was not available for our June session, and they still limit the number of people in the room to 16, which includes the presenters. So we decided to continue with the Zoom process. So last week, we held our second Zoom session. This time we advertised. I asked my Zoom exercise instructor to promote it. I sent the flyer to my Garden Ladies group. We sent flyers to the different chambers of commerce, and we submitted an article to the Hawaii Tribune Herald, as well as for the first time to West Hawaii Today. So on the day of the workshop, we had registered 33 people, and 27 of them actually linked in. We were pleased that 6 of them were from West Hawaii, because we haven't really been able to service that side of the island with the small group of volunteers that we have. For that workshop, our evaluation showed that 60% were over 65. Usually the 65 plus group is 85% or more. So the Zoom process brought a slightly younger group. And when we asked them how they liked the Zoom process, they loved it. We had only one individual who had never used the Zoom process before, and she was so excited and loved it. You know, she was enjoying every minute of the chat time before the program. If you'd like to know more about how we prep these folks prior to the workshop, I can do that later after everybody else has had a chance to do their own report, because I want to tell you about yesterday's first drive-through follow-up session in Hilo. And I see that Nick Los Banos is linked in, and he was there as one of our volunteers, so he can pipe in as well. At our in-person workshops, our volunteers serve as witnesses, and we provide 5 free copies of their completed Advanced Healthcare Directive. And those who are unable to complete their document at the workshop are encouraged to return 2 weeks later, where we provide the same services. So we wanted to provide the same opportunity to the Zoom participants. So we arranged to use the Office of Aging parking lot from 2:30 to 3:30 p.m. Our workshop last week was from 3 to 4 p.m. as versus our first workshop, which was from 9 to 10 in the morning. So 3 to 4 p.m. seems to work better for the Zoom workshop. We had a system where we placed 2 identical tags under the windshield of the cars as they arrived. And we had 4 volunteers who are experienced as document reviewers. And so as soon as the car was parked, one of us would go up to the car and show a sign that said, "Please put on your mask." And on the flip side of the sign, it said, "Please roll down your window." We asked if they had questions and answered them if they did. Then we checked their Advanced Healthcare Directive, and if they had missed anything, we had them complete it, then had them sign and date their document, and we of course matched the ID, their photo ID, with the document. So after we did all of that, then we signed on as the first witness, and then called our second group of volunteers who were we designated as the second witness, who also served as runners. So they would come up, sign as the second witness, return the ID and clipboard, to which we had already attached our evaluation form. And they asked the participant to complete it while they waited for their copies. Then the runner removed one of the numbered and colored tags from the windshield, took the completed Advanced Healthcare Directive, to have copies made. And we had volunteers in there, you know, who had everything set up perfectly. So when the 5 copies were made, any runner could return by matching the color and number tag on the windshield. In addition to returning the copies, we gave them plastic envelopes to keep it in, and also gave them flyers with our July and August Zoom schedule. These folks were very grateful for the service that we had provided to them. So we told them that the best way that they could help us was by giving our flyers to their families, friends, and relatives, and by telling them about our program. Hilo is a small town, so we have found that this works wonders, the word of mouth. I will be emailing the flyer to one of them because she said she would send it out to the Orchid Society roster and to 2 other organizations that she belongs to. So hopefully we'll be able to build our July and August participants with efforts like that. I do want to thank, on behalf of the community first, Kokua for all the resources that you provide and for all the help you gave us as we were trying to develop our own program in Hilo. Just a couple.
It looks like Amy got frozen. I don't know. Amy, can you hear us?
Yeah, I think the connection must be cut or something
Oh,
like that.
too bad. Well, hopefully she can call back in. I just want to say what an amazing effort. I hope they took movies of this. I think this is just incredible, like color coded and all of this stuff. I mean, I guess I could say nurses get stuff done, but wow, what a great, that is just a fabulous story. I'm hoping we can get Amy back in. We can get some more, I hope she hears about how impressed we are with that. But, you know, this is one of the challenges with Zoom, that things that sometimes people freeze and then we'll bring them back in. So that was really great to hear. And again, I hope we can get some movies of this activity in the parking lot of how they managed to do this in Hilo. That is very impressive. Okay, again, people can write questions in. I'm sure Amy will hook back in and then we can ask again.
Jeanette, you want to see if maybe Nick wants to add to anything that Amy had?
Oh, there's a good
mentioned?
idea. Was
Yeah.
anybody else present at this amazing event that has something to add? Nick, were you there, or Brenda, or anybody else from? Oh, good. Nick, what can you add? Did you take pictures, I hope, of this?
We have photos, but since I work for Hawaii Care Choices, I no longer sign as a witness. So my job was traffic. So if you've ever been, so that was at the Aging and Disability Resource Center, which some of you may remember I worked at. So I do know what the building is called, Jeannette.
I don't.
It's
Thank
okay.
you.
You'd have to visit more often. So because there are 2 entrances, and we had to just kind of funnel them through because we still had some other people coming in for other services. So we actually had part of the parking lot blocked off just for our participants so that they would all be lined up so the runners wouldn't have to run all over the entire 2 levels of parking. So that worked out really well. And the system was, they were running. Like when she says runners, they literally were running. I was kind of glad after like the 5th car that I was just doing traffic and guiding them to parking stalls because they were running in and out of the building, across the parking lot. But, you know, it was, you know, just talking to the participants who showed up that day it was incredible because they were so excited to like come to something and they were like, what are we doing? It's like, so you basically drive through, and I'm, you know, just explaining. And because I think people are getting anything they can come out to right now is it's something cool. So, and they were all ready with their masks. And so it was such a smooth process. I think if we had more volunteers, people could have got processed faster, because I think we had a total of, I think we had 13 or 14 cars come through, but there were multiple people per car. So that's what took a little bit of time for some of the crew to get through. But no, it was such a neat process, and we are doing the follow-up in the same way. So
That is just great. Nick, how many were documents were completed?
oh my gosh. So
You
if
know?
there are 13 cars, I think maybe 4 of the cars had at least 2 people doing their documents. So I think around 17 or 18 or so.
And I thought that the idea that you guys had of saying you're gonna run inside and make 5 copies, that was also really smart, because that you get something for free, you get, this is very helpful, emphasizing that you got to share the documents. So I thought that was great.
Something that Community First had supported the group with by buying a little copy machine. But before, we would give them the folder as the bribe, and then they would tell us that they were just going to put it away. We're like, no, remember, we told you in the class, you also have to share it with yada, 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 yada. And so we heard that comment often where people just thought, oh, well, it would be great if we could get a copy right there, because, now I have to go to Office Max and do this or whatever just to get a copy. So that was a little bit of a whipped cream and cherry on top of the whole Sunday, because that pretty much sets them up, right?
Yeah. Well, that is great. I think that was, what a great, kudos to you guys. That was really fabulous. What a great idea. And then you keep the momentum going. And I love it that people will come out to anything, including an advance directive signing event. It's like we are desperate to see people. Excellent. Well, that's great, Nick. Thank you for sharing. Hopefully we'll get Amy to come back, but thank you very much. And again, hopefully you can share some of those photos so we can share those with the group. I think you guys get whatever prizes, if we had them, for determination to make this happen. That is fabulous. So thanks for sharing, Nick.
Of course.
Can I just add something?
Of course, Brenda.
I just have to say that this community, Amy and her volunteers, Nick, so many people just giving so much time, and their whole action, their whole program under Community First is all volunteering, and it's been so enormously successful, and they just keep inventing and reinventing to make sure that it's effective, and reaching out in so many different ways that it's phenomenal. She didn't tell you the numbers, and I don't have them off the top of my head, how many people that in East Hawaii they've been able to get advanced directives completed for. But it's a lot. And we've been doing this for a long time and never have had the success that they've had. So great job, Amy, if you're listening, you and your team, Charlene and guys, you're just totally, totally awesome. So thank you.
Good. Thank you for adding that in, Brenda. Yeah, we love partnering with them, and it's a really great example of what you can do in a small town. I wouldn't even know how to start with that in Honolulu. So excellent. Great job. Okay. Next speaker is Susan Michihara. So Susan is the interim manager for the ambulatory social work at Kaiser Permanente, and a longtime member and participant in Kōkua. And we know that Kaiser has been doing an awful lot with outreach around advanced care planning. So we're really glad that Susan can give us an update today. So thank you, Susan.
Okay, can everybody hear me okay?
Great.
Okay, good. Well, thanks, Jeannette and Kōkua. I would just like to say that I have the privilege right now of being an interim social work manager for our group of 25, we call us ambulatory social workers. So we're the workers that are not the social workers in the hospital, but we're in the multiple clinics that are all over the state. So pretty much Oahu, Maui, Big Island. And I'm going to talk about our experience pre-COVID and then during COVID. So from that lens, I'll be giving my talk. I won't be, unfortunately, sharing too much about the whole Kaiser experience, hospital, all the other parts of Kaiser, but I do want to share kind of what we've learned and we've observed and we've gained from all of this. So first of all, 25 social workers, 20 of whom are we call switch social workers, and I'll talk a little bit more about that. But switch social workers target our very frail, vulnerable elderly. And we have about 4,500 of them across the state that we've identified through an algorithm. Then we have 5 other social workers who are outpatient social workers, and they take on everybody else from birth to death, all across the state. So these 25 social workers are the switch social workers, I should say, the one that deals with the frail of elders. Their goal is really to do upstream, kind of very proactive planning, having the conversations, building that relationship with the members over time, because once we enroll, is what we call our one of a frail elder to this switch model of care. We don't call it a program, but we call it a model that we hope to build on. So once we enroll a member into the switch model of care, we see them through until death do us part. So we have an opportunity with some of them anyway to establish a trust relationship, a relationship that we hope will we can use to influence, to be there during these different moments that they have in their lives, and to engage in a lot of this planning. One thing that we also really are trying to do with Switch is to influence our care team members, and that are our fellow workers, our providers, our PCPs, in terms of the way we want to look at member care. We want to make sure that we align to what the members' preference are versus the other way around. We are wanting to not be so prescriptive and say, this is the treatment method, this is the model, this is the strategy for care. But we're trying to be more aligned with what is it that you expect and want, member? What fits with your preferences? And then we're trying to align our care with that. So that's Switch. We've learned, I'm going to talk about 4 things that I'm going to compare pre-COVID and then COVID. The first is who initiates these goals of care conversations and ACP conversations. And pre-COVID, a lot of these conversations, of course, are a part of the Switch social workers workflow. We are talking about a deeper dive, figuring out what it is that our members want. We're talking a lot about preferences. So naturally, we're talking about what are your goals of care, advanced care planning and all of that. We did a lot of those kind of conversations. And I'm not to say that we own it. Of course, our partners in palliative care, in geriatrics, in continuing care, who made sure that they visited all of our nursing home members. We have different specialists who are, any of you have these conversations probably on a daily basis. But we noticed that since COVID, I guess these conversations became more normalized for our, especially for our physician partners. I think there were directives from their upper level leaders to say the expectation is you're going to have these conversations. We want you on a systematic basis to reach out to your members who have chronic conditions. And we want you to have these goals of care conversations, especially as it relates to the COVID what ifs. What if you were affected by COVID? What would you, what does your member want you to know? What do they want? And so we noticed that, of course, with that expectation, more physicians were having these conversations on a regular basis, we started getting an uptick, of course, in referrals for advanced healthcare directives posts and just the whole conversation. So it just made these discussions more normal. It brought more ownership to, I think, the providers. And whereas in the past, maybe we would have curbsides or consult often with our physician partners, they started doing a lot of the initial work directly bringing it up with members themselves. So that's one thing we noticed. The second area, pre and during COVID, that was changed is how we do ACP work. And I'm sure for all of you, this would be similar. Pre-COVID, social workers do a lot of telephonic work, or members would come into the clinic and we do face-to-face kind of discussions. We'd have our IDTs, our interdisciplinary team meetings, together in a conference room, and we'd meet. Since COVID, of course, that's changed. Many of us are working from home. Our IDT meetings are via Teams, which is our kind of Zoom platform. And we've started embarking on video visits. So a lot more, we call it healthcare anywhere visits. And that's something that social work is slow to jump onto that, but we are starting. So our physician partners, many others already have been doing a lot of these visits by video. Third thing that we've noticed is a little bit different pre and during COVID. Pre is our documentation. Pre-COVID, we would do of course, social workers have assessments, and our assessments for switch included maybe a few sentences. We start with what we call the know me category. So it's 2 to 3, 4 sentences, who this person is. That starts our chart entry. It's things that you might not find in the chart. It's not about just demographics, but how do they describe themselves? What do they want us to know about them? How were they brought up? What they identify with as a person? These 2 to 3 or 4 sentences kind of make you emote when you read it, because you kind of get a real feel for who this person is. So that would start our assessment. Right after that, we would have a statement called Know Me, which pretty much is maybe one sentence. What matters? What matters most is a sentence. We were going to say what really is most meaningful to this member. And you can expect a lot of things about family, about being independent for as long as I can, of staying in my home for as long as I can. So that kind of really was our pre-COVID assessments. In addition to that, we would, it was a very preference-based assessment. So we would always want to know what the members wanted in regards to medical aspects of care or end-of-life preferences. We would have started doing a lot of scenario building and social rescue plans. So that kind of means we're looking at the what ifs. We would engage them in what if your caregiver was not able to help you anymore? What if your function declines? And we would engage in, we call it scenario building, these what ifs. So that would be a typical switch social worker assessment. During COVID, of course, those things are all very important. Our social workers were calling all of their frail elders on their panels, and they were asking questions going over 5 key points. And let me see if I can find those 5 key points. They are, I'll get to that. Oh, here we go. Advanced healthcare directives, post, their medical intervention preferences, which really are like, what are their thoughts about hospitalization, about medical ventilation, end of life preferences, and then what is their current plan of care or their sort of living situation at the time. We would always start these this note by mentioning that there is a caveat, and that note says these preferences that we're gathering reflect the patient's wishes during this COVID-19 crisis. And we're asking whoever reads this note to please verify the patient's wishes as they, as they may change. So these 5 bullets were confirmed with our members as we did our calls, and we uploaded this into an area of the chart that was easily accessible for whoever's looking at it. It would be under really our problem list area. So that was something different that we've done since COVID. The 4th area and final area that we've seen a pre and post maybe difference is what I want to call advanced care planning and goals of care tracking efforts. We pre-COVID had started something called Gemba boards, and I'm not sure if that's a common term, but Gemba is a Japanese business term that refers to meeting around the front line, the assembly line, if you will, and top level leaders would come on a regular basis, once a month, whatever it is, to meet with their workers and to really find out from the workers' view what's working, what's not working, what are problems we can work together with the thought that it is the workers who best know processes that would work for them. And then this Gemba board would be a systematic method of documenting progress as this team worked together on furthering goals. So prior to COVID, we had adopted this, and it's a visual management board. It's literally a whiteboard where we would list things like enrollment. Enrollment means how many of our 4,500 members did this particular clinic enroll. Our goal is 80% of this 4,500, this group of 45 that we would enroll, meaning that we would touch base with, we would have assessed and brought into the switch model of care by the end of June. I think we're at 70 something percent, 73% maybe. And, we probably might not make 80, but COVID has done different things to our pace. So that's one thing. Another thing that we've been measuring is the advanced healthcare directives and posts. And so the combination of we're measuring if a member has either an advanced healthcare directive or a post, one of the two, where our goal is to hit 90%. And I think we're at 85%. So that's for this frail group of elders, of the 4,500 that I've mentioned. Okay, we've not been good post or during COVID. I can't say that we've been good about updating weekly, which is what we did, our numbers on keeping track of where we are with this. We have no leader rounding anymore because of, again, COVID. I am guessing we're going to start that up again, maybe virtually, I'm not sure how, but I think the belief behind this is that this visual management tool really sets goals for us and tracks goals for us in a very clear way. And it will speak to our leaders if we're not progressing on these goals, that it gives us an opportunity to share with our leaders that there's obstacles, perhaps, in why we're not going forth with having more of these advanced healthcare directives, post discussions, or preferences. Preference discussions are another one of the things that are on our visual management boards that we're looking at. So it keeps us accountable, it keeps our leaders accountable to us to help us problem solve and remove obstacles so that we can be successful in helping our members in the way that hopefully aligns with our leaders as well, because they want us to do this. So that's that's us. That's Kaiser social work in the ambulatory settings. And yeah, thank you all for giving us this opportunity to share kind of where we are pre and right now.
Well, that's great, Susan. Thank you very much. Can you speak at all of what you've identified with what the main barriers are?
The main barriers you mean in getting these conversations?
Yeah.
Okay. I think a big one, Jeannette, is where we want to have the conversations, but there has to be a readiness on the part of the elder that we speak with or the member, and this algorithm that tells us who our frail elders are. There's a whole range of different people, 65 and over. Some are really 65 and still working, but are considered frail because maybe they have a diagnosis that warrants that particular frailty. Or we could go all the way to being very, very sick and frail. And then there's the readiness in between all of that and being willing to talk. So an obstacle is possibly that not everybody's ready. And then an obstacle might be sometimes we really have to get help from our partners, our physician partners, because in order to have successful advanced care discussions, the patient, the member, has to realize that it's important for them to have one. And if we don't get our physician partners or just our partners to level set, if you will, with the patient to really help us, to help them to understand why this is important. That's sometimes one of the obstacles.
Sure. Yeah, no, I think that's often the case. I think the involvement of the physicians and what that balance is, and great. Well, thank you. We can talk more about that, but I think it's always important to say that the role of the physician is really crucial, and they can facilitate these conversations, especially, can be quite short. I've seen even some studies where it was, this is really important. We do this with all my patients. I'm so, we have a fabulous team. There you go. And I remember talking to Linda Dolan, who's a physician in Hilo, and that's basically what she said. That's like what I say. My nurse is great, and she's going to be talking with you. And so it's how you set it up and all of that. So I think it's just a really important, I think in the time of COVID, and it'd be interesting later we can ask Michelle that, the physician role is still really important. And I think getting around those steps of, it's just going to happen, that's not a reality. So excellent. Well, thank you so much, Susan. I think people can type in questions. We'll let Lori talk, and then we can come back for some more conversations and carry forward. So thank you very much, Susan. Okay, so next up, last but in no way least, of course, is Lori Protzman. I'm sorry, Hope is of course talking after Lori. Sorry, Hope, you don't get off the hook there. Lori is the Advanced Care Planning Coordinator at Queens Medical Center. Lori, maybe you just give a little overview of how you approach advanced care planning, and then you can tell us what you're doing in the time of COVID.
Sure. So my role is kind of like a three-legged stool. I have a community-based effort where through our Queens clinically integrated physician network, I'm having conversations with patients and families. I support our inpatient hospitalist team. So when a patient is admitted who's DNAR and they don't have a pulse, and our other clinical experts aren't necessarily engaged, like when our pain and palliative care team is involved, it's a routine part of their conversation to do advanced care planning. So there's no reason to add extra hands, or our social workers are involved, or our geriatric team, for instance. so I kind of focus on screening the charts and the records of the DNAR patients where the other clinical experts aren't involved, and have these conversations with patients and families. And the third arm or leg of my stool is doing education. So if I could just share that, you know, I love the fact that this community is so willing to share ideas, and I've taken wonderful suggestions that I've seen from HPH, and I'm going to see how I can work Amy's process into some of our Queens Clinic, because that was a phenomenal presentation of what she's doing. And I think there is creative ways we could facilitate community-wide efforts that don't have to be organizationally based. And I just love that thought of exploring. So kind of similar to what everybody's doing. So I'm not going to go in detail over Queens and how we differ. Maybe our uniqueness is that we have a community partnership as well. And when a patient that's at risk, that's part of our physician, Queens Physician Network, is discharged, our ambulatory team is alerted, and so we are on the case, starting with telephone calls within 24 hours of discharge, and then we have social workers, dietitian, nurses, and what we call navigators who go into the home and determine what level of support is needed and connecting them with community resources. The navigators will then take our most at-risk population and take equipment out to them, like pulse oximeters, thermometers, and the like, and blood pressures, so we can do our virtual sessions. But these navigators also help support getting the telehealth set up in the home in whatever format is possible. I think that's been one of the greatest challenges I've experienced, is that if I assume that they are going to be able to connect to me at the time that I'm going to discuss advanced care planning needs with them, in the beginning, it was just fraught with challenges. So now what I'm doing in the ambulatory setting is, since I typically would run an ambulatory clinic and have 8 to 10 people, patients, family members come to me at a Queens clinic, and I'm doing it now from home. What we're doing is we are identifying the at-risk population, like I say, from discharges, or we have analytics that tell us who our population base needs to be that we should reach out to. And then if they don't have advanced directives and or pulse when appropriate, then I'm setting up times to talk with them. We send a packet of information in a week in advance of setting the appointment, and in that packet, they get the directive, they get the pulse, they get Kōkua materials, they get the Kōkua website. I also prescribe the ACP decisions video that I'd like them to watch, so they just have to download the ACP decisions and then enter their code. So they're watching the video in advance of discussing with me, they're looking at the documents in advance of discussing, and then I'm meeting with them by telehealth. We're using WebEx, and that seems to work well, but like I say, probably the biggest challenge in the beginning was getting it downloaded and then getting them comfortable, and then not struggling at the time of our clinic appointment, virtual clinic appointment, by having ancillary staff set that up, have them do a dry run before the set meeting time. So by the time I make the call, if it's possible, they already know how. And if it's not, if it gets too complex for especially my frail elders or families who English is not their primary language, then we just go back to the typical telephone. So knowing in advance what I'm going to deal with has been helpful in the last couple of months when I'm trying to host these sessions. Similar to you guys, we have a template for documentation. Like you said, Susan, we use bullets. We identify, and we're finding that if we bullet 3 things right up top, rather than the narrative process, we feel that we're maybe more successful having our providers review the bullets and not read through the body of the documentation, trying to figure out what the goals of care really are. So we've asked the first bullet to be who will speak for them if they're seriously ill, what would they or would they not want if they were seriously ill, and then what's most important to them as a person that we should know that we could help support their loved one if they're not able to speak to us. Those are our 3 top bullets. those. And then in the hospital, we've developed a template that any of our healthcare team can use that's easy to just pull up and document or delete, whatever they don't like, but it just reminds them what we felt were the most important aspects of an ACP discussion that's having. I think another challenge for me has been, we have the conversations, but it's the follow through. Did they finish it? You know, what's the status? And rather than me trying to do all these follow-up calls, we haven't really negotiated what we can do as on the large body group of our many patients we're following, but definitely for my clinic patients that I'm having my virtual meetings with, our office staff are following up a week afterwards to say, well, tell us, you know, how it went. Did you do your document? What did you do with it? And they're putting another note in the chart and reminding them if they could send a copy to Queen's Medical Records and also to their primary care. But having listened to Amy's creative way of doing things, I think I'm going to kind of have a heyday and try to do that with some of our ambulatory Queen's clinics moving forward. You know, I've put most of our community-based education on hold. I did a couple of Zoom sessions with large groups. I think I had 20 where I was trying to do an ACP training, and you know, maybe I'm too old, but I'll tell you, I found the virtual training and role playing just too difficult to really make it what I felt worthy. So instead, I'm willing to do with our Queen's team, like I'm doing one next week with some new APRNs. I'm just gonna go to the clinic, my office clinic, and you know, 3 of us, and I'll do a unabridged training. But for right now, I've not opened it back up to the community nor to the 8-hour session until the November is my next scheduled one, depending upon how things go. Let's see. You know, the only thing I wrote myself a note was to say, for me, in my conversations with COVID and changing advance directives, I've kind of swayed in the direction of saying, you know, when you have COVID, it's a different kind of illness than most chronic serious illnesses. So allowing the fact that most people would want to be treated for COVID, and if they become very ill when they're at the hospital, it's their advance directive that will help coach their loved ones along if now they're in that serious end of life situation. Because you know, doing one and redoing it and making sure everybody's got the old and the new, I just thought I'm a little bit worried about that. So I've not been going in the direction of changing advance directives. Instead, I'm encouraging them when they have an appointment or a telehealth appointment with their doctor to raise the awareness of their doctor to say, I would want to be aggressively treated for COVID, but at the point if I was so seriously ill or end of life, then I want my advance directive followed. So the doctor could put something into the clinical note in that way. So that's how I've kind of been handling that. I think that's kind of, having listened into everybody, we're kind of very similar. I'm really pleased to hear that Kaiser, HBH, Queens were kind of aligned. And that makes me feel good about our health practice in the community and in our medical settings. So I think that's all I have to share.
Great. Well, thank you very much, Lori. So again, people should type in any kind of questions they have. And I'm going to go back to a couple of questions that we had for Michelle. She answered them in the chat, but maybe not everybody gets that. And I do want to follow up on what Lori said. It's, you know, we've been having these conversations with a smaller group over the last 3 months of what are we doing with advanced care planning. And it is really good to see that there are some really solid conversations and outreach and among the, you know, the major players. And I think one of my questions really is, how are we impacting people who would have been in the temple basement or come to a church talk, or people who aren't hearing about it through these, you know, through the groups that we've been talking about. So actually, I think what I'm going to do is have Hope go next, and then people should type in their questions, and then we'll jump into the question part. So thank you very much, Lori. That was great. And our last official speaker today is Hope Young, who I think many of you know, and she is the official advanced care planning coordinator for Kōkua. And Hope has, amazing but true, been doing this for 3 years, and you know, really just made such a huge difference of being out there in the community, talking to people, as well as doing trainings with professionals. So Hope, you're on.
Thanks, Jeannette. So what have we been doing as far as Kōkua goes for advanced care planning? Well, actually, we've been really trying to support all the providers by gathering resources and helping them with workarounds. We've discovered e-notary, so we've been doing that, but we are still doing advanced care planning sessions with groups that ask us to do it. So if anybody has a group that wants us to do it, please let me know. We did a couple for some caregiver groups, and the first one that we did was with Project Donna, and it was actually pretty cool because these were older individuals who were not comfortable with technology but had one meeting prior to this. So they really appreciated being able to get in and start talking story with each other because they normally met in person, but also to get this information because they see how important it is right now. So that was really great. We've also been looking at how to support service coordinators. They work for the health plans. And so we actually developed another presentation for advanced care planning during times of COVID. And it's not focused on the COVID aspect of it. It's more so focused on your workarounds, the things you can do while social distancing, while physically distancing, opportunities to change the way you're doing things. I actually did a virtual notary, and we're not putting it out there for the masses, but I've done one so far. It was a process. Some of the tips for virtual notary is, one, you need to make sure that there's a Wi-Fi connection wherever you're doing that. Two, you need to make sure whoever's on the receiving end has some technical abilities. And three, you need to have two phones, either two phones or a tablet and a phone, one which stays stationary and records the entire event on my side, and then one which you can send the documents back and forth. So it is a lot more intricacies than we're used to as notaries, but it is possible. The other thing that we've been doing is helping providers, helping the service coordinators with their workarounds via telemedicine, telehealth, trying to help them figure out how to do this. Not only are they normally doing things telehealth ways, but because of the COVID, it kind of changes the conversation and the direction of their conversation. So we're trying to help them and support them with the resources, the scripts from Vital Talks, just different things that are available out there, making sure that they know that that's out there. And we're doing all of these things to keep this network going. So if you haven't already been to one of our social workers meetings, even if you're not a social worker, and you want to just be involved with people on a regular basis, send me an email and I can give you more details on what's going on with that. Jeannette, help me. Is there anything else?
You know, that's good. I wanted people to know that we are, you know, if people are up for it, Hope is willing to do that. And I think, you know, I think if you think of a few people getting together to actually have a real conversation, it's especially what you guys were, like what Lori was saying, you know, maybe 7, 8 people could talk together and have interactions and things like that. So anyway, we're doing both the training for professionals and looking for people. And you know, it's really great to hear that, you know, when about 3 or 4 months ago, we were trying to figure out the right language and the balance. So we don't want to scare people, but this is a great opportunity. And people thought we were weird otherwise to be talking about this. And now we don't want to panic people, but it seems as though we've gotten a lot of things in COVID, operational things have happened. And maybe now is, again, the opportunity to keep up with these conversations. So, you know, on the other hand, all of you folks have been carrying on with these conversations. So I think this is really great, and it shows all of this really good work that's gone on. So if you guys think of opportunities or you hear of people, just, you know, let Hope know. And whether it's a pulse training, advanced care planning training, conversations, all that kind of stuff. And I do want to say, if folks find other resources for the Kokua website, let us know. Because there's a lot of good information. I kind of am now looking at I look at 3, CAPSI, Vital Talk for the conversations and the scripts, and then the National Post about, they have all sorts of good information for long-term care, for families, for conversations. So there's really good information. No need to reinvent the wheel out there.
So Sarah had a question. She's asking about e-notary sites. There are not any e-notary sites. As far as I know, I am probably one of the very few that are doing e-notaries, at least in our field. As far as other like financial or legal services, that might be a different realm. I am only offering to do advanced healthcare directives because I don't know other documents, although all I'm doing is witnessing a signature. But we're not making it a widespread offer. I don't want to be doing e-notaries all day. It did take about 45 minutes to do the one, so that it is time, there is some time constraints to that. So thanks for asking.
And we did it inside of Queens. Queens is an important member. They're very supportive of us. So if we can have these occasional things, that's fine. But so far, Hope's entire day is not taken up being an e-notary. But if people, so I'll put this out there, if people are notaries or they want to see how Hope did it, feel free to contact her directly and she can tell you more about that.
I will also share one more piece of a little nugget. My nephew was in the hospital and he actually needed his advanced directive completed. He wanted to name me as his agent. So when I got to the rehab, I just turned to his neighbors in the bed next door and asked them to be witnesses. And they were more than happy to be witnesses. It was a gentleman and his friend who was visiting. There are ways to work around this. So I encourage you to get creative.
Great. Okay, well, thank you, Hope.
Jeannette,
And
it's Lori, can I jump in for a quick thing?
Lori?
It's regarding the e-notary. So Hope was kind enough to talk to me and send me information that's needed. So I developed a workflow. I kind of put that into the chat because our staff said, oh, can we have like some walkthrough directions? So if you'd like, I could forward that document that kind of says step-by-step, do this in advance, make sure well, whatever, it's a workflow. So if that would be helpful, I'll make sure that Hope has it and she can send it to any of you, or just send it out and just pitch it if it's not of value to you, if that makes sense.
Excellent. Yes, Lori, that would be great. There we go. Kokua sharing resources, just what we want to see. I wanted to just
Jeannette.
Yes,
Jeannette?
Amy, you're back. Thank you.
Yes, I'm back and I want to apologize for leaving you, but my iPhone was saying that it was getting beyond hot. And so I have to get off. And so I missed, but I'm sure Nick and Brenda, I could see them speaking, but I couldn't hear what they were saying, but I'm sure they were able to answer questions for me. But if anybody has a question, I'd be more than happy to answer it.
Yes, well, both Nick and Brenda jumped in, and in the background, which is not me because I'm not a multitasker, I think Hope put together, or maybe Nick did, the photos from the drive-by. So you guys can see some of this. It's very impressive. I think this is so great. The drive-by witnessing. Okay, game on. You guys are awesome.
Well, you know, what we did pre-workshop was, as soon as somebody registered, we would email them and ask them, number one, if they needed help with the Zoom app, and number two, did they have a printer? And we attached all of the handouts that we give in our in-person workshop. And there were several people who didn't have a printer, so we would immediately mail out the Advanced Healthcare Directive to them. And then a couple of days after that, we emailed them the link to the 2 videos that we show in our in-person workshop, but which would have taken too much time in our Zoom workshop. And then we didn't give them the link until a couple of days before the workshop. And that also served as a reminder to everybody that the workshop was coming.
Super. And Amy, at the end of the day, do you know how many people actually witnessed? Nick thought it was maybe 17, 18.
Yes, we had 13 cars and 17 people. And
Fabulous.
what was interesting was that in the Zoom presentation, everybody was single that we knew of, but 4 of them apparently were able to help their spouse or son-in-law and daughter complete their documents. So we made copies for 17 people.
That's fabulous. Okay, well, good job. Thank you. And thank you very much for sharing. This is great. And I will, you know, when the opportunity emerges, I will share this nationally that you did drive by witnessing. I think it's so fabulous. That is really great. Okay, good. So let's look at some of these questions to make sure that I put them in here. So Michelle answered online, but I'd love it if you could talk a little bit about more. Jeff asked some more specifics about the COVID training that Dr. Soon and Dr. Price have developed, and you know, especially what how that's going.
So we haven't done any more as recently. Like I said, the last group was the inpatient social workers and the palliative care team for all 4 facilities. Just because the COVID numbers are kind of dwindled down, but not rising again. So because we're hoping to do the clinic physicians, because they had at the beginning of COVID, you know, we had created this script and they were interested in it, but it kind of died down, so we never went to the next step.
But so for folks that are interested, Dr. Soon developed a script. It's quite similar now to the Vital Talk. So again, at the beginning, it was like, oh my gosh, what do we say? And now there are some other tools, but that's also something that's available that I know we shared that through Kōkua network. Okay, so great, thank you. Yeah, hopefully, as you say, Michelle, hopefully we won't need that. Yeah. And Anita was asking if the patients are receptive to attending the monthly classes, but I was thinking, are the classes online, or you were doing that just in person with this very small number, right?
Before COVID, we were doing monthly classes at each at alternating the facilities. Palimomi Kapiranis dropped, and then COVID all got canceled. I was hoping to restart the public classes just as I am with the staff ones, or the clinic open to the in July, but we're not going to do that. Only for the and with the same intention of doing the physical distancing, the mask, at 9 registrations, but for the public, that's on hold. So, and that's why I want to thank you for sharing about the Zoom classes, from what Hope has learned, Susan, Laurie, that's very important. So maybe I can learn to do, because I haven't actually done a Zoom ACP with the public. So maybe I'll test it out. I have not done the e-notary because I just saw how complicated it was. And I would tell, if somebody really needed a notary, I was like, guess what? We are going to meet up and physically do it together. you know, so I would do that, but because it was just too much work in my brain. So thanks for sharing that. Yeah.
Right. Yeah, you know, one of the discussions yesterday in this national policy call was a number of states haven't made an e-notary, whatever it's called, an extraordinary decision at this time. And other people also have restrictions. They can only witness in person. So again, fortunately in Hawaii, it seems like we've been able to do some workarounds. And if anybody is having issues, I'd, you know, type it in or raise your hand and let me know. But so far we haven't really heard that. We've been hearing that it works pretty well. The workarounds are happening. Let's see. Anita was asking if you Hope, have any other groups that you've worked with besides like the health plan folks, the Project Donna. Hope has done, we're going to do a Project Echo talk with behavioral health providers, and we're also going to, I did one last month with the geriatric JABSOM group along with Dr. Takeshi Uemura. That these are not the same kind of interactive. So I want to say there's like, you know, there's different types that we're doing. There's one thing to have an overall general, what's a post, what's an advance directive, then you can have 100 people. If you really want to have a conversation, I think it has to be much smaller. We can't, you know.
Yeah, we've done some webinars. So Hi-Fi has recorded the webinars on their YouTube channel. So we have those on there. I think some of them actually have CE attached to it. You'd have to research it. We also have, as far as groups, we work with service coordinators, we work with patients, we work with caregiver groups, we work with all kinds of groups. Anyone who wants us to come and give them more information, and we pretty much tailor it to what their needs are. So we'll touch on all the different aspects of advanced care planning, but we really want to make sure that they're getting what they need from the presentations.
Yeah, exactly. So folks should type in questions. I had a couple of points that I wanted to share with this group too and get feedback on based on these national conversations yesterday. And they were looking to see what were changes that should be made. So, you know, interesting to see, like, things are totally impossible until they happen. So we can't do telehealth. Oh, we have a pandemic. I guess we better do telehealth. So part of the conversation in this was looking to see what are the, you know, what is it that we can be doing what can we be doing to keep these changes in place, or especially around telehealth. But there were a couple other ones that I wanted to put out there. So doesn't really relate, or may not relate to Kaiser. I don't know at the moment, even though I'm a happy Kaiser member. One of the questions was to remove any kind of copay around advanced care planning conversations, so that conversations should never cost money for people who, which I thought was really interesting. And I'm interested if people know what the situation is with the different health plans here, because I don't know that. So there right now is national legislation to push this. So if we could get this going in Hawaii, we'd be ahead of the game. Another thing was to have Medicaid use the CMS codes to pay for advanced care planning. So that's like another whole group of people who were, it was nice. It was cute. Yesterday, somebody said we could turn on the codes. I was thinking it's a lot easier. There's a lot more involved than turning on a code, but anyway, it's good. Another thing that was, I thought, really great was this recognition that there are a lot of people having conversations who are not being reimbursed. And there's a process. And, you know, Susan did that so well, talking today about the social workers and a series of conversations, and how are people, you know, it is for me, but not, it doesn't value the work that's being done to only reimburse at the very end. So this was part of his national conversation around billing for the time of well-trained social workers, nurses, chaplains. I appreciate they kept talking about chaplains. Clearly the discussion around telehealth was, needing to have that solidified, and then bringing up the topic of both broadband, which certainly for us and neighbor islands is super important, although sometimes here in my house, I wish I had better access. And then the discussion around reimbursing for telephone calls and not only reimbursing if there's a video option. So I thought that was another important thing. There was discussion about workforce development and training, which we know is really important. One of the other pieces that came up that I think Susan mentioned was this non-medical support for people. How are people getting food? How are people getting other supports? Because that is crucial for where we are right now, and this recognition that there's a lot of people who need that. They talked about how great PACE was, and I know we used to have PACE. If anybody knows what happened to PACE, that would be good. What happened to PACE and how do we get that back? And then the final suggestion was around helping support hospitals that are caring for people who are, they had some funny name for being poor, but basically disadvantaged at accessing resources. I was like, is that poor people? Because that's like, there was some new euphemism for poor people. So federally qualified health centers, certainly our state hospitals, county hospitals, things like that. So those were some of the recommendations that come up. So if anybody, for instance, knows about co-pays for any of our health plans, I'd be really interested in that, because that's certainly something we from the Kokua side can follow up on. Oh, and then there was one last thing, which I haven't heard of from people. So apparently early on in the pandemic, there was a waiving of the Patient Self-Determination Act, which meant that people didn't need to ask patients about their wishes. Apparently this came out of the amazing crisis that New York was in, with having so many people and they couldn't ask decisions. So they're really trying to, they're hoping that that people aren't doing that. But that is a question. Has anybody heard of that, or do they have that in their hospital, that the Patient Self-Determination Act, basically people weren't prompting patients and weren't asking about that? Anybody have that? I see Susan nodding or shaking her head, Michelle shaking her head. Valisa Saunders shaking her head. Okay, good. All right, so good we didn't get the memo on that one, but it's out there. So in case any of you hear about it, just whack that. Apparently in other places, people who were uncomfortable were saying, oh, we don't have to do this anymore, weren't prompting the patients, and yeah. So that's good to know. Excellent. Okay, so now that I can open my screen and look up here, you folks have done a fabulous job of presenting.